As I approach the end of my 5 years at medical school, I'm spending more time reflecting on my experiences to help me recognise the things that I can take forward to my clinical practice to help me become a better doctor. The role of a doctor isn't simply to provide the best patient care. Doctors must also have a great deal of professionalism, be leaders in the community, and be actively engaged in training the next generation of doctors. I feel that the most overlooked role is this final point, about being engaged in training future doctors. Generally speaking, I've found that the further into their career a doctor moves, the poorer their engagement and teaching of medical students. Now, that might be taken as an offensive statement to some, but of course it doesn't apply to all doctors. I've been with some exceptional consultants and registrars throughout my medical school journey. However, I've definitely had fewer negative experiences with JMOs, RMOs, and SRMOs than I've had with registrars or consultants. And I guess that's to be expected. The further that we get into our career, the smaller the proportion of our memory that our time in medical school occupies, and thus the more out of touch we become. And with less understanding and empathy comes poorer engagement. So in this video, I'm going to share 10 strategies that doctors can integrate into their practice to become better educators. I've broken these tips down into 3 tiers: the bare minimum, the good teacher, and the exceptional teacher. I'm coming at this from an Australian context, but I'm sure most of these apply universally to all doctors. And it goes without saying that there is an onus on medical students to be proactive and take charge of their own education, but I want to focus on the factors that doctors themselves can control to improve medical student engagement. Now, before we get into it, I just want to give a shout out to my friends Matt and Chris, who gave me really useful tips from their perspectives too. And finally, apologies in advance that this is quite a long video. It shouldn't be, but unfortunately, I've got a lot to say on this topic. The following 3 tips are what I classify as the bare minimum. If you want to be a doctor in the public health system, where teaching is a core component of your role, then you have to do these 3 things. Firstly, is to treat students like people. That is, with respect, kindness, and compassion. I'm ashamed that I have to write this because it's so obvious and so fundamental to being a human and how we would treat anyone that it really shouldn't have to be talked about. All people deserve to be treated with respect, kindness, and compassion. And doctors are pretty good at doing this with their patients, but often don't do the same with their medical students. Thankfully, this doesn't apply to most doctors though. Now, it also goes without saying that you should acknowledge your medical students and not just ignore them. You should learn their name and introduce them by name to patients or other healthcare professionals. I can't count the number of patient encounters I've been in where the doctor has introduced themselves to the patient and without skipping a beat has proceeded to take a history, and I'm just standing awkwardly on the side and the patient's looking at me thinking, who's this random bloke in the room with us? These suggestions are easily correctable and will make an immense difference to the student experience. Now, on a side note, medicine in Australia is actually much smaller than you might think, and it's inevitable that medical students will become colleagues with the doctors that supervise them. I remember the names and faces of every single doctor who was kind and respectful to me, as well as those who weren't. Building a sustainable private practice can be quite difficult, and inter-colleague referral is an important component of this. So simple things like treating people disrespectfully might actually be ruining your reputation and your career. Perhaps the most important factor that doctors must always keep in mind is the considerable power imbalance that exists between them and medical students, which only increases the more senior the doctor is. It would be naive to think that doctors forget this power imbalance exists, because evidence of the hierarchical structure of medicine exists everywhere. And I'm not saying that the power imbalance is a bad thing. Obviously, consultants bear the brunt of the responsibility for the well-being of their patients, and so are the ultimate decision makers, and that responsibility reduces the more junior that you become. But with increasing seniority, it does appear that doctors forget just how much influence they wield over the medical student. This influence can go so far as to alter which specialty the student chooses. So I personally think about it like this. If I have a significantly negative experience whilst on a particular specialty, then I will rule it out as a future pathway. And if I have a positive experience, it remains on my list. Therefore, the bare minimum goal is to not negatively influence students. If you can make it positive, that's even better, but neutral is a fine minimum standard. For example, on my psychiatry rotation, all the doctors, from the junior staff to the senior staff, treated me with such kindness and were so keen to teach and get me involved in being part of the team, and as a result, I had a wonderful time. And now, after weighing up a variety of different factors, psych is actually one of the top 3 specialties that I'm considering in the future. In contrast to this, my surgical experiences were extremely unenjoyable, which has concreted my desire to never become a surgeon. As a doctor, you wield incredible power in influencing the future careers of your students. And so, at the bare minimum, it's your duty to your specialty to provide an unbiased and accurate representation of it without negatively influencing the student. Whenever dealing with medical students, always remember your own experiences as a med student. Yes, every medical student has had unique experiences on placement, but there are also likely some universal emotions that we've all felt, or situations that we've all been in. For example, the feeling of being in the way. I remember the first time I was in operating theatre. I spent my first few hours anchored to this one tiny little corner of the room because I was just too scared to move anywhere else, lest I touch something I shouldn't have, or stand too close to the surgical field. And I was too scared to say anything lest it disrupt the flow state of the surgeon. So I stood in that position for hours, even between cases, until a registrar eventually told me that I could come closer, see the surgery, and ask questions. Another example is the feeling of dreading going to placement. There have been particular rotations where I've absolutely dreaded going into placement because I know what's coming is a barrage of difficult questions designed to make me feel incompetent, mixed with long periods of inaction and boredom as I observe the doctor perform their role without involving or engaging me. Interestingly, students share a lot of similarities with patients, particularly early on in their clinical years. They're vulnerable and at the mercy of doctors. They feel out of place in the new, unfamiliar environment of hospitals. They feel disempowered and they lack the confidence to do or say anything lest they be bothering the doctor. The more that doctors remember their own student experiences, the more empathetic and kind they will be towards students. If you're not content meeting the bare minimum standard and you're interested in being a good teacher, here are 3 additional strategies that you can employ. As previously mentioned, med students already lack confidence, and if they aren't given an environment in which it's safe to be curious without repercussions, then it may result in them shutting off completely. One of my favourite rotations was when I was with a registrar who made me feel comfortable asking any questions I wanted to, irrespective of how dumb they may have been, and who also didn't judge me for providing incorrect answers to his questions. The registrar fostered an environment where I felt safe, and where I had the freedom to be curious. And this meant that not only did I have an extremely enjoyable experience because I wasn't worried about being roasted for answering incorrectly, but I also learnt so much more because I was given permission to follow my curiosity. For all the med students out there, how often does a doctor sit down with you and ask you what you're interested in, what you need to accomplish for your university assessments, and what you want to get out of this particular rotation? If it's more than a handful of times, then you're extremely lucky. A lot of student anxiety comes from having assessments that you need signed off, but feel unable to ask your registrar or consultant because you know they're so busy. It was really lovely when earlier this year I was on a medical rotation and my JMO sat down with me and asked me exactly this, and then proceeded to advocate for me and help me get stuff signed off by actively asking the registrar on my behalf. Additionally, if you recognize that there are aspects of your learning that you think you are lacking, then having this discussion early on in the term allows for your team to cater for these needs throughout the rotation. So, for example, on day 1 of my general practice rotation, after being asked by my GP, I mentioned that I wanted to practice clinical examination as this wasn't something that I was particularly comfortable with. And then for the next few weeks, he allowed me to examine many patients, which was so useful for my specific learning needs at that time. Another benefit of early expectations is that if the team knows that you're interested in that particular specialty, then they may be more likely to get you involved in more of the specialized aspects of that specialty. And on the flip side, if you express that you aren't that interested in the field, then the team can just focus on getting you to a level where you're a competent junior doctor. So, for example, during my general surgical rotation in third year, I quickly decided that I had no interest in pursuing surgery. Yet, because I had never had a conversation with any of the doctors about interests and expectations, I was still expected to go to theatre and observe, which was incredibly low yield for me. I would have much preferred to remain on the ward and assist the intern with managing the post-op patients, a role that I would inevitably perform as a JMO, rather than having to watch many colonoscopies, which is a skill that I really never need to know how to perform. There are so many ways that doctors can improve the educational experience of the student by getting them involved and helping them feel like they're an integral part of the team. There are 5 main things, excluding soft skills like communication, that I believe students should learn about. 1 is specific topics, for example, things like hyperkalemia or asthma or Crohn's disease. 2 is clinical skills, for example, history taking or examination. 3 is interpretation of investigations like ECGs or bloods. 4 is procedural skills such as cannulation or nasogastric tubes. And finally, 5 is jobs, things like discharge summaries, organising consults, or writing notes. Doctors, as you go through each day, look for opportunities to get students involved in these and give the student autonomy and responsibility. Ask questions about topics that are relevant for working as a junior doctor and that are at the level that the student is expected to know. There's no point in asking students low-yield questions like, what's the mechanism of action of an immunotherapy agent like ipilimumab? Instead, focus your questions on high-yield situations that the student may actually come across. For example, you're in ED and you're about to see a patient with chest pain. What are some key differentials? If there's a big ward round held, tell the student to go and see some of the latter patients and formulate management plans and ISBARs so that when they join you later on, they can give you a handover. Run through scenarios that the student is likely to encounter in the early years of their career. For example, you're a JMO reviewing a type 2 diabetes patient with a pre-meal BSL of 21. What are you going to do? Give the students teaching sessions about specific common topics. For example, if they're on surgery, then something like the management of postoperative pain. Or if you're on gen medicine, then something like the management of constipation. If you're reviewing a patient's chest x-ray, ask the student to systematically interpret it. All of these things may seem really obvious now, but when you're busy and have a million things on the go, it can easily slip your mind to look after the med student's education as well. And now, for those of you who want to be exceptional, I've got 4 suggestions that'll make you a star in the eyes of any medical student. Don't forget your own experiences comes back in this level 3 because there are a few more things that you can do that aren't essential if you're looking to do more than the bare minimum. Remembering that as med students, we aren't paid to be in the hospital as much as we would like to be, and we have many other commitments such as studying for exams, doing assessments, undertaking paid work, having a social life, engaging in other hobbies, the list goes on. Therefore, if there isn't much going on or if it's very busy and the student can't help and you're too preoccupied to teach the student, then let them go home and do one of the other countless things that they could do. At the end of the day, in my eyes, and perhaps I'm unique in this viewpoint, the primary focus of med students is to pass their exams and assessments and graduate successfully. Of course, learning how to be a competent JMO is extremely important as well, but it's no good having all the skills but failing your exams and then having to repeat the year. Therefore, as doctors, recognize this. Actively tell students to leave because unless explicitly told to do so, rarely will students take the initiative and leave placement early. There's this cognitive bias called the curse of knowledge, which is basically where an individual who knows something forgets that others might not know that piece of knowledge. And how it applies in this context is that when you start working as a doctor, it's so easy to forget how little students know, especially early on in their clinical years. I personally feel that it's worthwhile explicitly stating everything that you're doing and your reasoning so that the student can follow your train of thought. This is particularly useful when it comes to diagnosis and management, performing procedures, and performing jobs like consults, as these are things that students have less experience with. So, for example, on GP placement this year, it was incredibly useful when the GP that I was with, who was performing a skin excision on a patient's arm, talked me through every step, from the method for injecting local anesthetic to why he selected a particular type of suturing material and suturing method. These thought processes that become second nature when you do the same things day in and day out as a doctor are not so obvious to students, and so making all those implicit decisions explicit is extremely useful. Feedback is a wonderful tool for promoting learning, but in my experience, it's very underutilized when educating med students. For example, I rarely receive feedback on my ISBA handovers, despite wanting some, because I know I've got a whole lot of room for improvement. And when feedback can be given, it's often blunt and non-constructive. A good model for giving actionable feedback is the McKinsey's feedback model. In this particular model, Part A is the specific action, event, or behavior that you'd like someone to change. Part B is the impact of that behavior, and Part C is a suggestion for what the person could do differently next time. So in this handover situation, a doctor might say, "You gave lots of detailed information about the medications, but I got lost in everything that you said. So maybe next time only mention the names of the medications, and I'll clarify the dosages if I want to." Obviously, this isn't something that you have to do, and even if you do it, it doesn't have to be regular. But sitting down and having a more casual chat with the student over a cup of coffee can be a great bonding opportunity and give you the space to get to know the student as a person. It really breaks up the monotony of the day and gives everyone something to look forward to. And unsurprisingly, the doctors who buy their students coffee tend to be the most liked. But I actually don't think it's because of the coffee. I think it's because if they're kind enough to offer the student coffee, then they're probably doing a whole host of other considerate things to increase the student's enjoyment of placement. So those are the 10 tips. If you implement all 10 of these strategies, you'll not only help the student learn more and have a much more enjoyable experience, but you'll also be revered by medical students as one of the few doctors who's also an exceptional teacher. On a more somber note, what underpins a video like this are the tragic statistics about the welfare of medical students and staff. This JAMA study found that in a sample with more than 120,000 med student participants, more than 27% of them reported depressive symptoms. Another study found that female doctors in Australia suicide at 2 times the rate of the general population. Of course, there's lots of contributing factors that we as individuals can't change, like staff shortages or the emotional toll of working with sick people. But we can all reflect on our behaviour and the things that we do or don't do that contribute to a toxic workplace culture.